The Recovery Kernel. Substance-Specific Navigation Series. How to recover from fentanyl. Using the Recovery Kernel Framework. Fentanyl, carfentanil, acetylfentanyl, M30S/blues/counterfeit pills, illicit supply fentanyl. Also covers, xylazine, tranq, co-contamination fentanyl test strip protocol. Warning: harm reduction resource, not medical advice. Crisis, call 911 or text 988. Fentanyl overdose kills in minutes. Naloxone may require multiple doses. If xylazine is present, naloxone will not reverse it. Call 911 for any unresponsive person. MAT, buprenorphine/methadone, is not just switching drugs. It is evidence-based medicine that saves lives. A note before you begin. The Recovery Kernel Compendium names fentanyl in its historical timeline with a precision that is also an indictment. 2013, present, fentanyl contamination, as prescription opioids tightened, supply migrated to illicit heroin, then illicit fentanyl, 50, 100x more potent than morphine, contaminating cocaine, MDMA, methamphetamine, counterfeit pills. The deadliest period in the epidemic's history. Every word in that sentence matters. The supply did not migrate by accident, it migrated because policy tightened access to prescription opioids without providing adequate treatment infrastructure for the people who were already dependent. The contamination is not random, it reflects economic incentives that make fentanyl cheaper and more profitable to produce than heroin. The potency is not a street phenomenon. Fentanyl was developed as a pharmaceutical, first used in anesthesia in 1963, and the same molecule that kills in nanograms is administered safely every day in hospital operating rooms because the dose and context are controlled. The people who have died from fentanyl, 110,000 Americans in 2022 alone, were not weaker than the people who used opioids 20 years ago and survived. They were using a different substance in a different supply landscape, often without knowing it. A counterfeit pill pressed to look identical to a 30 mg oxycodone tablet. A line of cocaine that tested positive for fentanyl. An unknown hotspot in a supply where the concentration is unmeasurable and unpredictable. This guide is for people who use fentanyl intentionally and want to stop. It is also for people who use any street drug and need to understand their fentanyl exposure risk. And it is for people currently using fentanyl who are not yet ready to stop but want to survive until they are, because harm reduction is a legitimate position and the compendium holds it. Section 0 contains the information that keeps people alive. Read it first. If you are in the presence of an unresponsive person right now, call 911, give naloxone if available, put them in the recovery position. Read Section 0 later. If you are reading this in recovery, already on MAT, or in the early days of trying to stop, the full guide is yours. The biology of what fentanyl did, the genomic profile that made it particularly powerful for you, the medical treatment that evidence says works best, the reconstruction of the endorphin system it suppressed, and the natural architecture of the connection and meaning that opioids were managing, all of it is here. The compendium was built for the deadliest period in the epidemic's history. This guide was built for the people surviving it. Section 0, Immediate Safety, the Naloxone Protocol. Warning: fentanyl overdose is the leading cause of accidental death in the United States. If you are near anyone who uses opioids, you need naloxone and you need to know how to use it. 0.1, Recognizing fentanyl overdose. Classical building the Centurion, the window is narrower than any other opioid. Fentanyl reaches peak brain concentration faster than heroin, oxycodone, or morphine due to its high lipophilicity. It crosses the blood-brain barrier with exceptional speed. This means the time from exposure to loss of consciousness and respiratory arrest is shorter than with other opioids. People can go from apparently alert to unresponsive in under 2 minutes. 0.2, The naloxone protocol, multiple doses may be required. Classical building the Centurion, the compendium's non-negotiable, carry it. Use it. Give multiple doses. The compendium states directly, carry naloxone, Narcan, if you or anyone in your household uses opioids. Available without prescription at most U.S. pharmacies. It is the difference between an overdose being survivable and not. For fentanyl specifically, a single standard naloxone dose may be insufficient. Fentanyl's high potency means more receptor binding that may require more naloxone to reverse. Standard naloxone dosing was calibrated for heroin. Fentanyl's potency means the receptor binding may outlast a single dose. Step-by-step naloxone administration for fentanyl overdose. Call 911 first. Not after naloxone. Not after rescue breathing. Now. Emergency services can be dispatched while you administer naloxone. Good Samaritan laws protect naloxone administrators in most U.S. states. Stimulate. Try to wake the person, call their name loudly, sternal rub, knuckles rubbed firmly on the sternum. This is a quick assessment step, do not spend more than 15 seconds on it. Recovery position. Roll the person onto their side to prevent aspiration of vomit. Tilt head back slightly to open airway. Give naloxone, first dose. Nasal spray, insert into one nostril, press plunger. Injectable, 0.4 mg IM into outer thigh. Rescue breathing if trained. One breath every 5 seconds. If not trained, focus on recovery position and naloxone. Wait 2 to 3 minutes. Observe for any response, breathing improvement, movement, eye opening. For fentanyl, do not wait the full 2 to 3 minutes if clearly no response. Second dose if no response. Give into the other nostril or a different injection site. Prepare third dose. Continue until breathing normalizes or services arrive. Up to 4+ doses may be needed for high-potency fentanyl. Do not leave them alone. Naloxone wears off. Fentanyl may remain. They can re-overdose after appearing to recover. 0.3, xylazine, the adulterant naloxone cannot reverse. Warning: xylazine, tranq, is an animal sedative increasingly present in the fentanyl supply. Naloxone does not reverse xylazine. Call 911 for any unresponsive person. Xylazine combined with fentanyl requires emergency ventilatory support. Xylazine, brand name Rampun, is an alpha-2 adrenergic agonist used as a veterinary sedative. It is not an opioid and is not reversed by naloxone. It is increasingly present in the fentanyl supply in the United States and has been detected in significant proportions of fentanyl samples in many cities. 0.4, the counterfeit pill crisis, M30S, blues, and pressed pills. Warning: counterfeit pills that look identical to pharmaceutical oxycodone, Adderall, Xanax, or Percocet may contain only fentanyl. There is no safe counterfeit pill. Every unverified pill is a potential fentanyl dose. The Drug Enforcement Administration has warned that 6 out of 10 M30 counterfeit pills contain potentially lethal doses of fentanyl. These pills are designed to look identical to pharmaceutical oxycodone 30 mg, same color, blue, same markings, M and 30, same size and shape. They are sold as blues, Mexican oxy, or simply 30s. They contain fentanyl mixed with other substances, or occasionally pharmaceutical oxycodone, and there is no way to distinguish them by appearance. Never use a pill that was not dispensed from a licensed U.S. pharmacy with a valid prescription, regardless of its appearance. Fentanyl test strips: dissolve a small amount of the pill in water, about 1/4 teaspoon water per 10 mg of pill, dip the strip for 15 seconds, lay flat and read at 2 to 5 minutes. 1 line equals fentanyl present. 2 lines equals no fentanyl detected. Available through harm reduction organizations and online. Test strips detect fentanyl at low concentrations but do not detect fentanyl analogs with certainty: acetylfentanyl, carfentanil, furanylfentanyl. A negative test does not guarantee safety. If fentanyl is detected, do not use alone, start with a very small amount, have naloxone present and someone who can respond. The DEA also reports fentanyl in counterfeit Adderall pills, pressed to look like amphetamine salts, counterfeit Xanax, pressed to look like alprazolam 2 mg, counterfeit Vicodin, and other pharmaceutical analogs. 0.5. Where to get naloxone. U.S. pharmacies. Naloxone is available without a prescription in most U.S. states. Ask the pharmacist. Generic naloxone nasal spray has become widely available and affordable. Harm reduction organizations. Many distribute naloxone for free, along with fentanyl test strips and safer use supplies. Nextdistro. Nextdistro.org mail-order naloxone distribution to eligible states. SAMHSA National Helpline 1-800-662-4357 can direct to local naloxone distribution programs. Emergency rooms and urgent care clinics prescribe naloxone to people at risk and their household members. Nextdistro's naloxone locator and Next's interactive map locates free naloxone distribution near you. Section 1. What fentanyl did to your brain. Classical building the Centurion, the most potent available mu-opioid agonist, active in nanograms. Fentanyl is a synthetic opioid, not derived from the opium poppy but created in a laboratory, that is a full agonist at the mu-opioid receptor, or. The compendium names this in the opioid withdrawal sonic protocol, endorphin system offline HPA axis in overdrive physical and psychological pain. Everything hurts, physically and emotionally. No internal pain buffer. That description is the exact language of what mu-opioid receptor saturation by fentanyl has done to the endogenous opioid system, and what its absence produces. Understanding the mechanism explains why recovery requires rebuilding the endogenous system rather than simply stopping the exogenous one. 1.1. The mu-opioid receptor system, what was borrowed from. 1.2. Why fentanyl is different from other opioids. Classical building the Centurion, 100 times more potent than morphine, the number that explains the crisis. 1.3. The hotspot problem, why fentanyl supply is uniquely unpredictable. Classical building the Centurion, the same bag can contain a dose and a death in adjacent amounts. Fentanyl is not evenly distributed in illicitly produced supply. When fentanyl is mixed into a powder or pressed into a pill, the distribution is not uniform. Some portions of the batch contain far more fentanyl than others. A single bag of powder may have an amount that produces the expected effect in one line and a lethal amount in the next portion of the same bag. This hotspot phenomenon is unique to fentanyl and does not occur with heroin or prescription opioids at typical doses. It is one of the primary reasons that tolerance developed to a previous supply does not protect the user from the next supply, even from the same source. The hotspot problem means, I've done this amount from this source before, is not safety information for fentanyl. Start with a much smaller amount than usual after any break in use, after supply change, after release from incarceration, after medical care, or after any period of reduced tolerance. After even 3 to 4 days without opioids, tolerance drops significantly. A dose that was ordinary before the break can be lethal after it. The most dangerous period for overdose is the 2 weeks following release from incarceration, hospital discharge, or any supervised abstinence period. Tolerance has dropped while cravings and supply access have returned simultaneously. 1.4. The supply contamination landscape, fentanyl in everything. The compendium, contaminating cocaine, MDMA, methamphetamine, counterfeit pills. This is no longer occasional cross-contamination, it is the structural reality of the current illicit drug supply in the United States and increasingly globally. Section 2, Your Genomic Blueprint. Fentanyl has a specific and clinically important pharmacogenomic profile. The compendium explicitly flags CYP2D6 as potentially fatal for opioid metabolism and OPRM1 for mu-opioid receptor sensitivity. These genes determine who needed higher doses to feel the same effect, who experienced more intense pain sensitivity in withdrawal, and who responds differently to MAT. The DNA testing panel for fentanyl recovery. Phenotyping without testing. Did opioids work less well than expected at standard doses, required higher doses than peers to feel the same effect? Likely OPRM1A/G or GE/G variant. The reduced receptor binding affinity requires more drug for equivalent effect, and makes natural endorphin rewards feel less satisfying at baseline. Did you use fentanyl primarily for pain rather than euphoria? COMT Met/Met, higher pain sensitivity, plus OPRM1G allele, reduced natural pain buffer, plus possibly MTHFR, reduced endorphin precursor synthesis. Chronic pain management is a primary recovery track, not an afterthought. Did other medications affect fentanyl more than expected, particularly HIV medications, antifungals, or certain antibiotics? CYP3A4 drug-drug interaction. Know your CYP3A4 inhibitors and inducers. This affects the safety of fentanyl use and may have been creating unpredictably intense effects. Do you also have significant alcohol or benzodiazepine use? Possible GABRA2 high-risk haplotype. Combined withdrawal from opioids plus alcohol/benzos is medically dangerous. Medical assessment before any attempt to stop. Was anxiety or emotional pain the primary driver alongside physical pain? SLC6A4 short plus COMT Met/Met SAGE profile. Anxiety treatment is a parallel recovery track. Section 3, Medication-Assisted Treatment, the medicine that saves lives. Classical building the centurion, MAT is not just switching drugs. The compendium's position is unambiguous, it is medicine. The compendium is explicit about this. A prescription that keeps the system stable while underlying conditions are being addressed is a scaffold, useful, appropriate, time-limited. A prescription that substitutes for addressing those conditions indefinitely has become its own form of dependency. The scaffold that prevents the building from being finished is not serving its original purpose. For opioid use disorder in the fentanyl era, this framing applies with one critical addition. In many cases, the scaffold is what keeps the person alive long enough to do any building at all. The evidence is unambiguous. Buprenorphine and methadone reduce opioid overdose mortality by 50 to 70%. People on MAT stay in treatment, reconnect with family, return to employment, and survive. People who discontinue MAT or who cannot access it die at dramatically higher rates. The recovery kernel does not treat MAT as a lesser form of recovery. It treats it as the primary medical intervention for a medical condition, the foundation on which the rest of this guide's work is built. 3.1, the 3 FDA-approved MAT options. 3.2, MAT for fentanyl-specific considerations. Warning: fentanyl's higher receptor binding affinity means buprenorphine induction may cause precipitated withdrawal if started too soon after last fentanyl use. Discuss induction timing with your prescriber. Several aspects of fentanyl's pharmacology require adjustments to standard MAT protocols. Buprenorphine precipitated withdrawal. Because buprenorphine has high receptor affinity but partial agonism, if given while fentanyl is still occupying receptors, it displaces fentanyl and causes sudden precipitated withdrawal, far more severe and rapid than standard withdrawal. Traditional guidance was to wait until moderate withdrawal symptoms before buprenorphine initiation. Newer low-dose, microdosing, induction protocols, Bernese method, allow initiation without waiting for full withdrawal. Discuss with your prescriber. Higher methadone doses for fentanyl. People dependent on high-potency fentanyl often require higher methadone doses for adequate stabilization than was standard for heroin-dependent patients. Standard starting doses may be inadequate. Dose titration guided by clinical response rather than historical averages. CYP3A4 and buprenorphine. Buprenorphine is also CYP3A4 metabolized. CYP3A4 inhibitors increase buprenorphine plasma levels. Disclose all medications to your MAT prescriber. Duration of MAT. The evidence supports extended, often indefinite, MAT rather than time-limited courses. Stopping MAT prematurely dramatically increases relapse and overdose death risk. Duration of treatment should be driven by clinical stability, not arbitrary timelines. 3.3, How to access MAT. SAMHSA treatment locator, findtreatment.gov or 1-800-662-1414 4357 finds buprenorphine prescribers and methadone clinics by location. Any licensed prescriber, 2023 onwards. Buprenorphine can now be prescribed by any DEA-registered physician, nurse practitioner, or physician assistant without the previous X-waiver requirement. Telehealth. Buprenorphine, numerous telehealth services, Dun Health, Bicycle Health, Ophelia, Monument, and others, provide buprenorphine prescriptions remotely, significantly expanding access. Emergency departments. Many emergency departments can initiate buprenorphine during an emergency visit and connect to outpatient follow-up, the bridge prescribing model. Low threshold and same-day access programs. Some clinics offer same-day buprenorphine induction without requiring abstinence documentation or insurance. Cost. Medicaid covers MAT in all states. Medicare Part D covers MAT. Many private insurances cover with prior authorization. Patient assistance programs exist for uninsured. Section 4, Biological Reconstruction, Rebuilding the Endorphin System. Classical. Building the centurion, the system is not broken. It has been outsourced. Recovery is bringing it home. The compendium's opioid withdrawal framework is precise. Endorphin system offline HPA axis in overdrive physical and psychological pain. Recovery is the process of bringing the endorphin system back online, rebuilding the capacity for natural endorphin release, restoring more receptor density and sensitivity, and normalizing the HPA axis that has been hyperactivated by chronic opioid suppression. Everything in this section applies whether or not you are on MAT. MAT stabilizes the MR system at a functional level, it does not rebuild it. The supplement and behavioral protocol in this section supports MR system recovery while MAT maintains stability. 4.1, The Methylation Foundation. 4.2, Endorphin System Reconstruction. Classical. Building the Centurion, DLPA, the supplement that extends the life of your own endorphins. 4.3, Pain Management in Recovery. Classical. Building the Centurion, the pain was real. Recovery requires managing it without opioids. Many people reading this guide had legitimate pain before fentanyl, during fentanyl use, and will have pain in recovery. Opioid use disorder does not mean the pain was not real. For most people with fentanyl use disorder, there is genuine physical pain, injury, chronic condition, neuropathic, that the opioids were genuinely addressing. Recovery from opioid use disorder requires a pain management plan that does not include opioids. This plan must be established with a physician, ideally one who understands both addiction medicine and pain management. The following non-opioid pain management approaches have evidence. 4.4, Withdrawal and Pause Management. Acute opioid withdrawal from fentanyl can be severe. The compendium names it, HPA axis in overdrive physical and psychological pain. Everything hurts, physically and emotionally. No internal pain buffer. Clonidine, alpha-2 agonist addresses the HPA axis overdrive of withdrawal, reduces autonomic symptoms, sweating, anxiety, rapid heart rate, high blood pressure, goosebumps, without acting on opioid receptors. Available by prescription. One of the most effective withdrawal comfort medications. Side effects, sedation, low blood pressure. Loperamide, Imodium 4 GI symptoms of withdrawal. Acts on opioid receptors in the gut without significant CNS effect at normal doses. Caution, very high doses of loperamide have been misused for opioid effect, use only at recommended doses for diarrhea management. NSAIDs and acetaminophen, for the generalized pain and muscle aches of withdrawal. Magnesium glycinate, for the anxiety, insomnia, and muscle cramping of withdrawal. NMDA antagonism and GABA receptor support address multiple withdrawal mechanisms simultaneously. Hydroxyzine, non-addictive antihistamine with anxiolytic properties, supports sleep and anxiety during withdrawal without adding addiction risk. Pause. Post-acute withdrawal syndrome. Opioid pause can last 6 to 18 months with episodic dysphoria, anxiety, insomnia, and craving. The NAC/DLPA, exercise, and connection protocols from sections 4.2 and 6 address pause directly. Document pause episodes to reveal the pattern. 4.5, Sleep Reconstruction. The compendium's opioid withdrawal sonic protocol, 60 to 75 BPM, warm frequencies, bass, mid-range, emphasize 528 Hz, ambient, new age, classical strings, nature sounds, legato, no silence gaps. Music with emotional warmth, not just beats. Nostalgic music from childhood can help. Melatonin, 0.5 to 1 mg sublingual, 30 to 60 minutes before target sleep time. Low dose. Opioid withdrawal produces severe insomnia. The HPA axis overdrive and the absence of opioid-mediated sedation mean the system does not downregulate to sleep. Melatonin provides the circadian signal without pharmacological dependence. Magnesium glycinate, 400 mg elemental evening. NMDA antagonism and GABA support for sleep onset. Glycine, 3,5-G, 30 minutes before bed. Core body temperature reduction, primary physiological sleep trigger. L-theanine, 200 to 400 mg evening. Alpha wave promotion, reduces the anxious hyperarousal that opioid withdrawal produces. 5-HTP, 50 mg evening. Serotonin-melatonin conversion for sleep architecture support. Sleep in MAT stabilization is often significantly better than in acute withdrawal without MAT. Methadone and buprenorphine both have sedating properties that support sleep during induction. This is a genuine quality-of-life benefit of MAT beyond its overdose prevention function. 4.6, Hepatitis C and HIV assessment. Classical building the Centurion, the infectious disease priorities in fentanyl recovery. Hepatitis C, HCV-4 opioid use carries very high HCV transmission risk. HCV antibody test at baseline. If positive, HCV RNA for active infection. Treatment is now curative, 8 to 12-week direct-acting antiviral course with 95% plus cure rate regardless of genotype. Treat HCV during recovery. Do not wait for more stable recovery. Curing HCV improves recovery outcomes. HIV test at baseline for any 4 opioid use. If positive, ART initiation immediately. U equals U, undetectable equals untransmittable, at suppressed viral load. Note, many ARTs are strong CYP3A4 inhibitors, they dramatically affect fentanyl metabolism. Disclose all substances to your HIV provider. Hepatitis B, vaccination if not immune. Test for active infection if 4 use history. Bacterial endocarditis, fever, heart murmur, or unexplained fatigue after 4 opioid use requires urgent cardiac evaluation. Endocarditis from 4 drug use can be fatal without prompt treatment. Wound care and vein health, for fentanyl use damages veins progressively. Wound care assessment, vein rest during recovery, appropriate wound management for any injection site infections. 4.7, Peptide Support Layer. Section 5, The Fentanyl Craving, Understanding and Interrupting. Classical building the Centurion, the most lethal craving in this guide series, because relapse after abstinence frequently kills. Fentanyl cravings in recovery carry a specific lethality that no other substance in this series matches. The craving itself is not more intense than opioid cravings generally, but the consequence of following it, after even a brief period of abstinence, is potentially lethal. Tolerance drops within days of stopping. A dose that was ordinary before the abstinence period is frequently fatal after it. The person who relapses to fentanyl after 2 weeks of abstinence is using an unknown dose of an unknown supply with dramatically reduced tolerance. This is the clinical context that the craving interrupt protocol operates in. Every interrupted craving is not merely a recovery win, it is potentially a life. Fentanyl Craving Trigger Map. The Fentanyl Craving Interrupt, 5-minute protocol. Call your support immediately. Before any other step, call or text your support person, sponsor, MAT prescriber, or 988. The fentanyl craving's lethal consequence if followed makes immediate connection the first priority, not the fifth. Execute 4-7-8 breathing, 8 cycles. The HPA axis overdrive of fentanyl craving requires more parasympathetic activation than standard. 8 cycles. Do not abbreviate. Take DLPA, NAC, and magnesium. DLPA extends your body's own endorphins. NAC addresses the glutamate component of the craving. Magnesium addresses the HPA axis and anxiety. These are pharmacological interventions for a pharmacological state. Name the trigger precisely. Pain. Pause. Environmental cue. Emotional pain. The name determines the parallel response: pain management, pause protocol, environmental exit, crisis support. The name is the first cognitive intervention. Change your environment immediately. If near a high-risk environment, physical exit before anything else. If in an emotional crisis at home, change rooms, go outside, go to a public space where using is not possible. Execute your natural endorphin activation. From Section 6, vigorous exercise, meaningful human connection, any activity that generates genuine endorphin release. The craving is pointing at an endorphin deficit. Fill it through a source that does not carry lethal risk. Document. Trigger, type, intensity, action, outcome. After 3 weeks, this data reveals your specific risk architecture, when, where, and what produces the cravings, with the precision that makes genuine protection possible. Section 6, Building the Natural Endorphin Architecture. Classical Building the Centurion Paper C-28 applied to fentanyl recovery, the pain buffer the body already knows how to build. Fentanyl provided something specific, a pain buffer so complete that physical and emotional pain became tolerable, the world became softer, the self became quieter, and the social disconnection that chronic pain produces briefly dissolved. The endorphin system the brain was designed with can provide all of these, incompletely, less immediately, with effort, but genuinely and sustainably. The opioid sonic protocol from the compendium says it: human connection and warmth, singer-songwriter, folk, acoustic, sad music is appropriate, it validates the grief process. Recovery is not the forced suppression of pain. It is the rebuilding of the system that metabolizes it. The natural endorphin architecture. Section 7, Navigating the Recovery Kernel, your protocol map. Section 8, The medical context, the epidemic, the medicine, and the gap. The compendium's historical frame is the only appropriate opening for this section: the prescription opioid epidemic, Purdue Pharma, OxyContin, the Sackler family's $13 billion while 400,000 people died, the supply tightening that drove people from prescription opioids to heroin, and the fentanyl contamination that followed. The current crisis was created by deliberate commercial decisions and enabled by regulatory capture. The people who died and the people who are still using were not failed by their own character. They were failed by the systems that profited from the pipeline and then criminalized the people stuck in it. 8.1 The Regulatory and Policy Context. DEA ex-waiver removal. 2023 buprenorphine can now be prescribed by any DEA-registered provider without the previous special waiver. This is the single most important policy change for fentanyl recovery access in decades. It means your primary care physician, your emergency room, your urgent care, all can prescribe buprenorphine. Ask for it. Good Samaritan laws, available in 47 states, protect people who call 911 for an overdose from prosecution for drug possession at the scene. Know your state's law. Call 911. The fear of prosecution should not prevent calling for help. The incarceration barrier. As with crack cocaine, fentanyl use disorder disproportionately intersects with the criminal justice system. Drug court, MAT in correctional settings, and re-entry planning with MAT continuation are the specific interventions for people navigating the legal system alongside fentanyl recovery. Insurance coverage. All Medicaid programs must cover MAT as of federal requirements. Medicare Part D covers MAT. The ACA prohibited insurers from requiring prior authorization for buprenorphine as of 2023 in most cases. If coverage is being denied, file an appeal, contact your state insurance commissioner, or seek legal aid. 8.2 Clinical Guidelines and Resources. SAMHSA, Substance Abuse and Mental Health Services Administration. FindTreatment.gov for treatment locators. 1-800-662-4357 for navigation assistance. SAMHSA's Tip 63, Medications for Opioid Use Disorder, is the federal clinical guideline. American Society of Addiction Medicine, ASAM-ASOM.org, publishes clinical practice guidelines for opioid use disorder treatment. National Alliance of Advocates for Buprenorphine Treatment, NABT.org, Patient Advocacy and Provider Finder. Nextdistro.org, harm reduction supplies including naloxone by mail in eligible states. Smart Recovery, smartrecovery.org, evidence-based, non-12-step peer support. Narcotics Anonymous, NA.org, peer support through the 12-step model, specifically addresses opioid use disorder. National Drug Helpline, 1-844-289-0879, 24/7. A final word. Classical building the Centurion, the deadliest period in the epidemic's history, and the people surviving it. 110,000 Americans died of drug overdose in 2022. The majority involved fentanyl. 110,000 people is more than died in the Vietnam War. It is more than died of HIV at the peak of the AIDS epidemic in 1995. It is happening in every state, every county, every demographic, every income level, though not equally, and the inequalities follow the same lines they always have. The people who died were not weaker than the people who used opioids before fentanyl arrived in the supply. They were given a molecule that is 100 times more potent than morphine, distributed in a supply that cannot be standardized, in an era when the treatment infrastructure was still primarily built for a different substance. They were failed before they ever put the pill in their mouth or the needle in their vein. The recovery kernel was built for the people who ran out of time before anyone told them their biology was not their weakness. In the fentanyl era, some of those people ran out of time because naloxone arrived 90 seconds too late, or because the counterfeit pill contained a hotspot, or because they left incarceration on a Friday and treatment wasn't available until Monday. For the people who are still here, the medicine works. Buprenorphine reduces overdose mortality by 50 to 70%. That is not a marginal improvement. It is the difference between most people dying and most people surviving. The evidence is unambiguous, and it has been unambiguous for 2 decades while stigma and policy argued against making the medicine available. The compendium named the gap, treatment infrastructure absent, punishment substituted for medicine. Recovery from fentanyl requires that the gap be named before it can be navigated. The biological work in this guide, rebuilding the endorphin system that fentanyl suppressed, addressing the pain that drove the use, developing the genuine human connection that more activation always knew was the real target, runs on top of MAT, not instead of it. The endorphin system knows how to generate the pain buffer, the emotional analgesic, the social bonding warmth, and the sense that the weight is manageable. It was doing it before fentanyl arrived and it will be doing it long after. Recovery is giving it the conditions under which it can. Every day sober in the fentanyl era is an act of survival. Every naloxone dose administered is an act of love. Every person who makes it through to the other side and reaches back carries the most important available evidence, that the other side exists. This guide was built so you could find it. Naloxone, any U.S. pharmacy without prescription treatment locator, FindTreatment.gov crisis, 988 SAMHSA, 1-800-662-4357. Refer to the Recovery Kernel Complete Centurion Compendium for all referenced protocols. Crisis, call or text 988 Emergency, 911 SAMHSA, 1-800-662-4357 National Drug Helpline, 1-844-289-0879. Warning: harm reduction resource, not medical advice. How to recover from fentanyl using the Recovery Kernel Substance-Specific Navigation Series.